by providing better care, which will come with the use of MIOCT. These two studies, the Pioneer and Discover study, gave us the idea, the evidence of nicheness of MIOCT. I will straight away move on to the cases. Subretinal injections are coming up in a big way, and giving subretinal injection is going to be need a hell of a precision there, as you cannot afford to go wrong because kind of costs involved in the injections. Nothing better than MIOCT can show you the precise location of the drug delivered. Here in this case, a TPA, and it is seen as a blood formation, which you're seeing in this case. It provides the flawlessness in diabetic surgery by ensuring the right plane, complete removal, and that too without the use of the adjuvants. So you will appreciate in this video that how we are able to achieve and see these things the right plane, as I've already said, without causing any damage to the retina. And once the dissection is then we will see that whether the removal is complete or not. This cannot be seen with any other modalities than with the OCT with its microscopic integration. And again, once you have removed the membranes, you need not use any adjuvant to confirm what you have done. This same flawlessness is needed in the eyes with the good vision, where it ensures on table that you have completed the job with precision for which you have come inside the eye. And these are the eyes you see of epiretinal membranes, and you don't want any surprises on the post of day one. Smooth study done at our center showed that its usefulness when it is compared to the standard operating microscopes and the digital viewing systems. Now, there is a war for godliness in case of macular holes. So we want to achieve 100% macular hole surgery. And this war cannot be fought without MIOCT. The right and the precise precision of the materials which we are using to close these large refractory macular holes can be seen intraoperatively with MIOCT only. Exact position and whether this is a small flap or a large flap, it cannot be, precisely done without the use of MIOCT. Here in this patient, we used this technique, and we have a few patients, not many, and we have done now 3-4 cases where we have used MIOCT to do this job. And this cutting edge maneuverability and with the little bit of innovation, what we are able to achieve is we are able to do and use this tool in eyes where we are not doing vitrectomy. We are just using light from the outside and the viewing systems. We are able to see the children under anesthesia, and we're able to see their areas of interest, and this saves a lot of money to invest in another OCT device to see especially children under general anesthesia. And as we are moving to diagnostics, the confidence of going into an eye for sampling for any tumor increases once you have MIOCT, because actually you can see the yield coming into the your aspiration tube. So you can see here in this case we have used a silicon tip, and you can see the material is moving into the cells are moving into the system. I thank Dr. Mohit for giving me this wonderful case, and he has lots of experience of doing these biopsies in case of the lymphoma patients. Now, as we have moved into the digital viewing systems, now people have thought of integrating this MIOCT into the digital viewing systems, and they have been success stories. And because I think it is going to amaze us the way the digital system and the way MIOCT looks on that. And it is really amazing actually. This is our system where we have integrated our Zeiss into an Alcon viewing system, and we try to you can see how beautiful the view is, and you are able to see exactly the tissue you're cutting. And here in this case, because I wanted to leave that island of hyaloid there in the center, because I never wanted to make a true, it's a big hole there in the center. So this is how into a digital system the MIOCT has been incorporated, and it's a really amazing view, and it's a very enjoyable surgery. And again, it's used in cornea surgery is no less than the VR surgery, because they are also dealing with the cornea, which has some layers there. So as VR surgeons, we can sometimes tread into their areas and show them that we still have in us with the use of OCT. As you saw that this patient had descemet membrane detachment at the start of the surgery, which we took care with the Helon. And then at the end of the surgery, we're putting this air there, and you can see the descemet membrane is going back and going into its place, and see how patient is done post-operatively without me looking for anterior segment surgeon there. So in the end, MIOCT provides me the precision, flawlessness, cutting edge, and confidence while I'm treating my patients. So I thank you again for Professor Dogra sir and my teachers and for students for this wonderful opportunity. Thank you.